Now, I would like to call upon Dr. Anu Paul, who was present before you. Sorry, JG sir, for keeping you waiting. This is FP545, Evaluation of Skills Transfer in Short-Term MSICS Training Program using ICO Oscar.
Good morning, everyone, respected judges and dear delegates. Today, I am presenting evaluation of skill transfer in short-term manual small incision cataract surgery training program using ICO Ophthalmology Surgical Competency Assessment Rubrics, ICO Oscar. The authors have no financial interest to disclose. MSICS is a widely accepted, cost-effective and affordable technique which is shown to yield similar surgical outcomes as phacoemulsification. Surgical training requires standardized curriculum and a well-structured program. Earlier studies were concentrated more on the subjective analysis of trainees' surgical performance by a preceptor or a mentor. The focus has now shifted to more objective assessment of the surgical competence, mainly by tools like ICO Oscar SICS, which is internationally valid and reliable tool which is used in this study. Methodology: it was a retrospective observational study carried out from June 2019 to May 2022 at a tertiary care eye hospital in South India. A total of 95 trainees were evaluated during 1 month MSICS training program using ICO Oscar scoring. The trainees were divided into 3 groups. The first year residents consist of 17 trainees. They were the first year postgraduates without no prior MSICS experience. Second group was the fellows. 64 trainees were enrolled in this group, and they are the post-residency surgical trainees in the institute, lasting of 1.5 to 2 years and having varying previous MSICS experience. The third group was external trainees, 13 trainees. These are practicing ophthalmologists from other centers having varied MSICS experience and who are enrolled in the surgical training program for 1 month. This 1 month program is a dedicated surgical skill transfer program which involves hands-on MSICS training along with wet lab training, operating OT observation, lecture classes, and one-to-one discussion sessions on MSICS. Patients having age-related nuclear cataract grades 2 to 3 with pupillary dilatation of cyanamum and prominent eye were selected for the study. All complicated cataracts and non-case of glaucoma, corneal or retinal pathologies were excluded. Patients with deep socket, systemic high-risk patients, and patients with postural abnormalities were also excluded. All trainees performed MSICS with IOL implantation under subcutaneous anesthesia under continuous observation by the trainer through a observer eyepiece and a display monitor. If the trainee noted any difficulty in any of the steps, it was rectified by the trainer so that the trainee could proceed to the next step without compromising the patient safety. Any major intraoperative complications like scleral desensitization, premature entry, posterior capsule rupture, and zonal dialysis were managed by the trainer. All trainees maintained a surgical logbook with ICO Oscar scoring sheet. The scoring sheet was duly filled in by the trainer after completion of each case, and complications, if any, were also noted and discussed with the trainee. The data entered on the scoring sheet was evaluated for surgical skill by calculating the average mean scores and improvement in the mean scores in last 5 cases as compared to their first 5 cases. The scores in the first and last 5 cases were considered as the initial and end mean scores respectively. This is an example of a scoring ICO sheet which is used in the study. Results: a total of 1,842 surgeries were done by the trainees. Mean age of the trainee was 32 years. Average number of 19 surgeries was done by a single trainee in 1 month period. Each case was divided into 18 steps as per the ICO Oscar grading. And in the study, prolapse of nucleus into anterior chamber and nucleus delivery was marked as a single step. Maximum score of 5 per step and total maximum score of 90 per case was given. The table 1 shows the difference in the initial and end training scores. The first year residents showed statistically significant improvement in scores from the initial to end mean scores. To start with, the first year residents had very low initial mean score, and this was statistically significant. And towards the end, all the 3 groups had no difference in statistically difference in the mean scores. The learning curve was evaluated by plotting the mean scores in set of 5 consecutive cases and observing its trend. It is evident from the figure. The blue line shows the first year residents. They had a increase in mean scores starting from the beginning of the course itself. And the fellow group, which is shown in the red line, they had an initial high scores and they maintained a plateau curve. The external trainees also had a high initial score, and the graph increased towards the end of the training. Capsular access and tunnel construction are two important steps in cataract surgery. So it was seen that the first year residents had a statistically significant improvement in scores from the beginning to the end of the training. Considering the tunnel construction, all the three groups had some improvement in the scores, but it was not reaching statistical significance. Complication observed in the study in the groups, the most common complication in all the three groups were in tunnel construction, especially as premature entry. And the external trainee group had the highest rate of posterior capsule rupture and zonular dialysis, whereas the first year residents had the least of PCR and zonular dialysis. Come to discussion. Surgical skill assessment is necessary to know the progress made by the trainees and to improve the training program as well. Several tools were used in the previous studies like OASIS, GRASIS, and surgical video assessment for the same. So ICO SICS provides an objective benchmark for comparative purposes. The lower mean scores of first-year residents can be attributed to their lack of prior MSICS experience, but showed significant improvement in the learning curve during the 1 month. The difference in the mean scores between the groups significantly reduced towards the end of training. This shows that a proper structured training can help the trainees without any prior MSICS experience to be at par with those who had experience. Tunnel construction and capsular access contribute significantly to the surgical learning curve and complication. Most common complication made by first-year residents were in tunnel construction, 3.3%. External trainers had higher rate of PCR and ZD, previously acquired improper skills and that required unlearning and relearning. The ideal technique could be the reason. Conclusion: short-term 1 month MSICS skill transfer program is efficient and significant, especially for novice surgeons, and ICO OSCAR is a useful tool for assessment of skill transfer. Thank you, sir.
Thank you, Dr. Anu.
Thank you, madam, for the nice presentation. Now you have talked about the common complication, the premature entry.
Yes, sir.
All blades given for every case were disposable, or there is nothing like sometimes it is third time, fourth time, where that makes a lot of variation in the.
Yes, sir. It was disposable blades, crescents was used.
So every case was given a new disposable blade.
Yes.
Of the same company.
Yes, sir.
Even company also it makes a difference.
Yes, sir. Yes.
Now when the outside fellows came for training,
yes, sir.
initially there is some deterioration when subsequent 5 cases of study.
Yes,
any specific reason, and then suddenly there is jump between 4th and 5th case.
Yes, sir. We analyzed.
Means any specific reason, or they are tense in your operating in your institute for the first time?
Maybe they are getting used to the environment actually,
Yes,
because everywhere the OT environment can be different now. So
because other trainees were used to your institute. That might be a probable reason. By any chance, I think you are in a big institute. Any surgical simulator is there in your institute?
Exactly.
Yes, sir.
You are from Arvind?
Yes, sir.
Correct. Well, that
So
gives
they
a
were
very
trained on
nice
simulator.
Yes, sir.
Okay. Yeah.
it gives a very nice analysis of the case. That
for
is a different thing.
especially for the beginners, sir, those who have not done hands-on on human eye, they get a very good that intraocular spatial orientation and tissue feel with the tactile
feeling is there. And one more question, which is not a part of your paper.
Yes, sir.
You must be giving training for phacoemulsification also.
Yes, sir.
On an average, who learns faster? Phaco is learned faster or SICS?
Sir, personally, I feel if you have a very good experience with MSICS, it is a very short learning curve for phacoemulsification.
No, for raw patient.
For the raw student.
Raw student.
So would you, the basic question would be, would you allow a raw student who does not know SICS to learn phaco right away? Yeah. And how would your ICO OSCAR be helping in that one?
Okay, sir.
I have asked this question to many institutes.
No,
and
abroad actually they don't train MSICS, they just directly train phaco. So can we compare? You can make two groups of students. One you throw them for directly for phaco, and second for.
It's not a part of this study,
so
but I'm just asking.
Maybe in the future.
Your experience in the institute.
I think that's a very.
I asked this question to many institutes. They say phaco is learned faster. The reason being there are so many phaco masters everywhere in India and abroad. You get to see a lot of good videos, lot of good training programs are there. There are very few SICS expert surgeons, though SICS is commonly done. So it is a painful learning curve for MSICS. And phaco is comparatively easy. Complication chances are very less. All our phaco masters, they have done a lot of complications in their learning stage, because for them nothing was there for learning. But all these youngsters, they do minimal complications in phaco now.
So from my
on the contrary, MSICS is very painful in learning.
Yes. From my small experience, what I feel like is phaco is more of a machine dependent, whereas MSICS is more of a skill and hands-on. It's required. Sir. Thank you so much.
Yeah.
And our Gen Z is more tech savvy. I think that is one thing. They're more tech savvy.
They're more tech
Yeah.
savvy. See what happens in phaco, we are worried about the endothelium because of phaco energy.
Yes, sir.
But now they know the good techniques, so that damage also
Even
is
the
not there.
machines are very...
But in MSICS, if you don't respect endothelium, it is very common. The cornea gets complicated, and MSIS unnecessarily then carries bad name.
Definitely, sir.
Simco versus IA. Manual versus that makes a difference.
Yeah.
Okay, thank you, Dr. Anu, for that presentation.